This wasn't around per se or well talked about, previously. I mean, this has come on the scene in just the last few decades, but
What are specifically some of those like new innovative approaches?
I've really spent the crux of my career trying to expand that. In pain school, initially, we were educating about all these different modalities such as acupuncture, Tai Chi, yoga, mindfulness, biofeedback. We would educate about those things, but we never had any services to back it up.
Towards the end, you didn't even bring up opioids until the last point that you said. And I think there's this huge misconception when it comes to pain management where it's like, you're in my office, I'll write you a prescription for an opioid, get out of my office, that's pain management.
Yeah.
Welcome to Rarely Discussed, an American Porphyria Foundation podcast with your hosts, Andrew McManamon
and Nicole Castellano.
We have porphyria, a rare disease. Rare diseases differ greatly, but share many similarities in how they affect our lives.
Being rare can feel lonely and isolating, but we're stronger together. Join us in meaningful interviews with porphyria and rare disease experts and the patients and families impacted as we connect, learn, and heal together.
We'll talk diagnosis, treatment, pain, mental health, managing daily life, and everything rare. Welcome to Rarely Discussed. This is episode number 9, and we have a very special guest, as of course I say that every single time because we always do. And I thought, Nicole, you could take the reins and introduce our guest.
Thank you, Andrew. Today we indeed have an extra special guest. We had talked about her in one of our earlier episodes. Her name is Dr. Judith Hudson, and she is a psychologist specializing in chronic pain and addiction. She works for the VA and also serves on the American Porphyria Foundation Scientific Advisory Board. And her focus is on the neuroscience of pain and alternative treatments for chronic pain. So, Judith, thank you so much for being here today. We really appreciate it, especially being September, being Pain Awareness Month. So thank you so much for being here.
Yeah, thank you for having me.
Great. All right. Well, so can you just kind of tell us a little bit about yourself, where you're from, where you practice, maybe more about your role as the acting department head of integrated wellness, and like what it means to take a whole health approach to pain management, and just kind of start there.
Sure. So again, I'm Dr. Judith Hudson, and I was born and raised in Chicagoland area. I live in a suburb of Chicago. And I am a clinical psychologist by trade. I've been working in the field for decades. I have my own practice, but I also work at the Captain James A. Lovell Federal Healthcare Center, which is in North Chicago, Illinois, and it's the only integrated facility in the nation, meaning that we service not only veterans, but also active duty, beneficiaries, dependents. And as Nicole mentioned, currently my role, I've been working at the Federal Healthcare Center for 14 years, and I was originally hired on as a health behavioral coordinator with a specialty in behavioral medicine, health psychology, and my background is in pain management. But I currently serve as the acting department head of our new integrated wellness department and the acting whole health clinical director. And I'm also the section chief of all non-interventional pain services.
Well, that sounds like a lot.
Right.
Yeah.
My goodness.
Yes. Our department is new. The integrated wellness department is something new. I have spent my whole career kind of leading up to this point. It was a vision to really integrate pain management services as well as whole health services. The VA has really done an amazing job with leading the charge for a whole health transformation towards healthcare. That started around 2011, but really, I think our footprint at our facility started in 2016. Around that time, I was teaching pain school and then morphing that into more of like a pain university, which is a very comprehensive approach to pain management. It isn't just approaching it through prescribing medications or doing physical therapy. It's about educating the patient through more of a neuroscience approach, educating and partnering with the patient by putting the patient in the driver's seat and, working with them, collaborating with them to really set up their individualized treatment plans, partnering them with a pain coach, someone that's going to walk the journey with them to really help them to discern what truly matters to them. And I think that's the crux of whole health, is we flip the script from focusing on what is the matter to what matters to the person, and really putting them in the driver's seat to identify not just that they want to work on their health issues. I mean, because this is just beyond pain management. This is how we approach chronic disease in and of itself. So really looking at it, moving beyond just physical, but incorporating all these other issues through a more of a biopsychosocial approach. So I don't know if that answered your question, Nicole. It's kind of a roundabout.
No, absolutely. That sounds amazing because, especially in porphyria, it's a very painful disease. There are a lot of rare conditions and chronic conditions that are very painful. And it's really what this is so different, because really it's, I have pain, either acute or chronic, and what can I take for it to stop it? And a lot of times in porphyria, even opioids or, heavy pain meds aren't enough. And I'm really excited. I know we've talked about this a little bit before. I'm really excited about, trying to bring some of that, into with the APF, kind of bringing that in and helping patients with that. So I'm so interested in this approach. It's very exciting because the way it is now, it helps, but it's not really enough, it seems like, as far like what are specifically some of those like new innovative approaches, like specifically that you're working on in this program?
Well, I think I mentioned when I got to the VA, they really just had medications and procedures and traditional modalities such as physical therapy. And so I've really spent the crux of my career trying to expand that. In pain school, initially, we were educating about all these different modalities such as acupuncture, tai chi, yoga, mindfulness, biofeedback. We would educate about those things, but we never had any services to back it up. And so over the course of the years, I created this vision to have more of an integrated approach. So we're not just looking at the physical aspect of the person's chronic disease state, whether that be chronic pain or some kind of like chronic type 2 diabetes or cardiac or pulmonary, but really looking at all the other factors that play into it. The biology is just one piece of the puzzle. There's also the psycho and the social aspects of it, and really trying to create a program that incorporates all those factors. So when I mean incorporating all of those factors, I approach pain management through the treatment with a multitude of services, from looking at motion-based, recreational-based, behavioral-based, and medical and interventional. And so what does all of that mean? It's approaching it where the patient's at, really looking at the patient as a whole instead of just their symptoms and their disease state, because their disease impacts every aspect of their life. And I know with porphyria, it's devastating, and it impacts every area, from just how you function on a day-to-day basis to, what you can do, what you can't do, your relationships, everything. And so we look at each patient uniquely and individually. We sit down with them, we do an intake to really listen to their story. Because oftentimes, and part of the reason why I'm doing what I'm doing and why I'm so passionate about all this, is I'm also a chronic pain patient myself. I've been living with chronic pain my whole life. I've struggled with migraines since I was a little girl. And in my early 20s, I woke up one day and I had lower back issues where I couldn't move. I went to my doctor, found out that I had a really bad herniation, had to go see a neurosurgeon after an MRI, and had my first surgery. The surgery helped, but then I got pregnant and there were more issues that came about. And subsequently, I've had 8 back surgeries to date.
Oh my God.
I've got enough hardware in my back to set off the alarms when I go through security. But that's part of the reason why I'm passionate about what I do, is I've gone through the gamut with treatments. I've been treated like an addict. I've been treated like, I'm drug seeking or it's all in my head. And so I really made the push to come up with an education where it kind of dispenses or does away with the fear regarding what's going on with me and not knowing what's going on with me. So that's kind of where the neuroscience comes into play to really educate better about what is going on in your body with respect to your pain. And then not just that, but then taking from that, what can we do about it? How can we help you? We're not here to kill the pain, because pain does serve a purpose. It protects us at its very core. But with chronic disease, and particularly with chronic pain of any nature, the body gets really good, the brain gets really good at replicating it and experiencing it to the point where we become hypersensitive with our pain experience. And so really looking at how can we make a difference? How can we impact? And looking at how does pain or your chronic disease state impact your life? And then tailoring. So we sit down with patients, we come up with a personalized treatment plan. We look at all the areas from movement to nutrition and diet, to your surroundings, your relationships, power of the mind, spirituality, all of these areas about how your pain, your disease impacts your life. And then we educate patients about what services might best suit their needs. And we set goals with them. We help them develop, their treatment plan with regards to how they want their functioning to improve. And then that's where the services come into play. So we offer like more of the conventional, traditional physical therapy, occupational therapy. But then, when I'm teaching classes to my pain patients, I talk about recreational therapy. Why do you think that would be important, Nicole?
To recreate, like get up and move around?
Yeah. Well, it
Yeah.
isn't even getting up and moving around.
Yeah.
It's
Well,
getting
I
out.
think to take your mind, I would say to take your mind off of things, to distract you when I know for me anyway, and I've talked to a lot of other patients, sometimes when that pain comes, Andrew has said before, it can swallow you whole. It's all you can think about. And
Yeah.
so that is something that I do. When I am in pain, I will specifically try to find something to, even in the middle when it's really bad, just try to think about something else or read, or just, sometimes you can't, but if you try, you get to the point where you can. And I think that it's hard not to think about it when it's that intense, but that's what I would say. It would kind of help to move through it a little bit better.
Yeah. And so it's arming people with a multitude of tools. Distraction, as you were just mentioning, is one of them. But we talk about recreational services because oftentimes with pain, I liken it to, as you were referring, it can be very dehumanizing. It can literally strip us of our humanity to the point where we feel very helpless and hopeless, and we become very isolative, and we start to pull away from other people, relationships, doing things, and just life in general. So incorporating activities in a safe environment. We have a partnership with the Nature Center where we will bring patients out and they can go on, we call it Walking Wednesdays, where they just walk around in nature and kind of get out with other people. But we also offer art classes, music classes, equine therapy, which is working with horses. I mean, these are things that in and of itself, it's not going to fix your pain, but it does start to get you back into life again and working with people, doing things that you used to do that you enjoy doing, or maybe finding something new that you do like to do that you didn't know before. So there's that piece of the puzzle. And then of course, behavioral based services. Some of those are like cognitive behavioral therapy, believe it or not. That's one of the gold standard treatments for chronic pain, as well as a multitude of other chronic disease states. It isn't just for mental health issues. I mean, for instance, with chronic pain, we look at how your thoughts impact how you feel about just your overall life in general. And based off of those two, how is that impacting what you do, what your activity level is? And then all three of those kind of define your reality. And so we tease that apart, starting with your thoughts. So I explain it as you have a pain flare. And like for me, on a given day, I'll wake up and, my back is locked up or my neck is throbbing so bad that I have a major migraine. And the first thought that comes through my head is, here we go again. Why is this happening to me? When is this ever going to stop? Why are my doctors not on this? Why can't they find something to get rid of it? And as that's going through my mind, then the feelings are coming in where I'm starting to feel anxious and frustrated and angry. And I get to the point where I start to feel more helpless and hopeless about my situation, to the point where my pain is escalating even more so because I'm hyper focusing on it at that point. And then I decide I'm just going to call off work. And so I don't go into work and I end up staying in bed or hanging out on the couch watching Netflix marathon, and my activity is lessened. And as I lessen my activity, there's deconditioning that's happening with my muscles and my overall activity is decreasing. And as that happens, it's fueling and increasing my pain again, which then triggers more of those negative thoughts. And this cycle just goes on and on. And so we break it down and we partner with patients and we first work on the thoughts, because the thought really defines your reality, as I explained. But I call it, we catch the thought, we check it for the validity, and then we challenge it. And then from there, we address the emotional piece through doing some relaxation or distraction or what have you. And then we look at how can we improve activity, whether that's, starting with just basic stretches just to get a person moving, or setting up a walking plan, but really tailoring it to the patient. And as we're addressing it through all those modalities, their life starts to change a bit and they start to reapproach and redefine their reality. So that's cognitive behavioral therapy in a very brief explanation, but that's one of them. Some of the alternative modalities: hypnosis, biofeedback, mindfulness, meditation, some of the medical interventional. We all know about injections or epidurals or trigger points or joint injections to help, but it doesn't fix the issue. There are other modalities with regards to the physical. At our facility, we offer traditional full body acupuncture, which can be very beneficial. It works with the chakras and the life meridians. And then we also offer battlefield acupuncture, which is auricular, where you get semi-permanent needles put in your ear. They're like no bigger than the size of a pencil eraser. They look like little thumbtacks. They come out after a few days. But these are alternative modalities that they aren't for everyone, I will say. But for some people, it can be life-changing. It can be a good piece of their treatment plan. Just as hypnosis can be, or biofeedback, or working with pharmacy. That's another big one. One of the things I developed at the facility was our interdisciplinary pain clinic. Per the CARA Act, the Comprehensive Addiction Recovery Act, which was put out under President Obama's presidency in 2016, it mandates, they had a certain section for VA, but it mandates that every facility has to have pain management services that's beyond just opioids, and then have a pain clinic, as well as offer whole health services. The pain clinic is an interdisciplinary team, so it isn't just a physician. It's a pain provider. It's a behavioral medicine specialist like myself. There's a physical specialist, a physical medicine rehab specialist, and then there is an addiction specialist. And we also have incorporated a coach on our team that kind of walks with the patient to work on that ever important treatment planning, and really helping, partnering with them and listening, but also looking at the medication aspect, because that is a piece of the puzzle. I have amazing pain pharmacists that work with me, and we educate patients about the roles that medications play. And we have many patients that are still on opioids. Back in 2016, the CDC put out guidelines not to stop opioids, but stating that, research doesn't necessarily support opioid as a first-line treatment for chronic pain. It didn't say not to use them. There's no there's no legislation or directive or law that states that a person cannot be prescribed opioids or that providers can't prescribe. It's just, it's not the first line of defense, because opioids in and of themselves, they really don't address the pain. They kind of numb it out so people can be more functional. And particularly, when you have acute flare-ups, they can be helpful in some situations. But our pain pharmacists also educate about other medication options, such as, looking at the role of antidepressants a lot. And it's not just for depression. It actually helps with the neurotransmitters in our brain that can help to reuptake some of the chemicals such as dopamine and serotonin. There's a lot.
I'm sorry to interrupt you, but would that kind of help, like you were saying earlier, to have different thoughts? That's where it's kind of connected?
Well, I mean, the medication itself isn't going
right.
to.
I mean, to keep you in a state that, I'm sorry, yeah, it wouldn't make directly, but it would help keep you, if it works, to help keep you in a more positive state, to support you, to make it easier not to go into those negative thoughts.
Absolutely. But there's actually different dosages that are used specifically for pain management than it would be for mood disorders. But yes, you can use it in combination with that. There are other medications such as non-steroidal anti-inflammatories or muscle relaxants. We've also, even though it's not federally legalized, we educate our patients about marijuana. In the state of Illinois, it is a legal thing. We can't prescribe it at our facility, but we do have the ability to educate about it. It doesn't help everyone, but it can be one of those tools in a person's toolbox to utilize. Some people get a lot of benefit from it. I know the data with regards to porphyria is inconclusive, I think. I don't know if there's been a lot of research that's been done. I know they're just in general with marijuana. I know they're trying to do more, but specifically with porphyria, I've known of people who have porphyria where they've gotten a lot of benefit from it, and then others not so much. And that's also part of my whole thing, is that a person really needs to have their treatment tailored to them specifically, because not every treatment strategy is going to be beneficial for every person. Every pain story, every disease state is very unique. Your pain issues are very different from mine. I mean, I have one of the biggest pain issues at the VA is lower back pain. I can have 10 people in a room that all have lower back pain, but they experience it very differently. And that's why it is so important to have an interdisciplinary team and an individualized approach where we put the patient at the center of their care. They're in the driver's seat working with us. Now, mind you, that's not where, they're dictating what their treatment is, but they're setting their goals. I mean, I often ask,
they're giving you their input. So you guys learning what people's goals are, what matters to them, like you said. So then you can with your expertise, try to help them get a program multidisciplinary that's going to work for them.
Yeah. I mean, I've had patients where they come in and one of their goals is, like, I had a woman, she always would ride around campus on a scooter. She's in her late 50s, early 60s, I believe. She's a veteran. And she would be, I would see her all over campus riding a scooter, to the point where she got her own scooter. She got a van to hold her scooter. She used it everywhere she went. Her goal and why she came to see me was because she wanted to become more active. She wanted to become more active because she wanted to go out with her friends and her grandkids out to eat. And the restaurants that they would go to didn't accommodate her scooter. And so she wanted to learn ways to become more active. So I met with her and, I did the intake and looked at what was going on. And she had had 2 back surgeries, one at her L4, L5, which was pretty successful, but it didn't really address all of her issues. So they had to go back in and do a second surgery. And this one was a lot more extensive, where they had to insert some rods and screws and a plate to stabilize her spine. And so the patient was saying that if she were to not use her scooter and go into some of these restaurants without it, she would fear that she might trip on the curb or trip on the carpeting in the restaurant. And by tripping, she then might fall and dislodge the plate in her back, and it would sever her spinal cord. Now that's very extreme and it's
Right.
over magnified, but just even with your reaction, it's like, whoa, where did that come from? But that for her was very real.
Sure.
And so it was looking at, well, what do I do with that? So I partnered with her provider, with her neurosurgeon. He actually works at Rush Press in Chicago. And we sat for a really long time, just the three of us, going over her history, looking at her films, looking at whether this hardware was going to move or what it was going to do. I also have, as I mentioned, a lot of hardware in my back.
Right.
I had an artificial disc implanted, which failed, and then they had to put a cage to surround my spine to stabilize it. So I'm very familiar with hardware and the likelihood of what it will or won't do. So with all that knowledge, we brought the patient into our conversations and really educated her about what the hardware could do, what it wouldn't do, the likelihood of it slipping or severing her spinal cord. And ultimately, I didn't fix her pain, but what we did was it helped to ease some of that fear that goes along with pain. And by doing so, patient was able to start going out. She goes out maybe once a month, maybe twice, but it's improved her functioning and her overall just approach to life. She's happier that she can see her friends, her grandkids. So that's what I mean by working with the patient where they're at. I mean, she didn't come in and say, Dr. Hudson, you've got to get rid of my pain. I just can't tolerate it. Although I do have some people that do come in with that. And then we sit and talk about what matters. Why do you want your pain to improve? Let's have that conversation. So really flipping the script a bit and looking at what the motives are, and then moving forward with recommendations about, what might be beneficial and what might not be.
No.
There's just so much to unpack there too,
I
just
know.
based on everything that you've said. Just going back to the beginning and going through all the behavioral and the cognitive and doing all that aspect. I mean, towards the end, you didn't even bring up opioids until the last point that you said. And I think there's this huge misconception when it comes to pain management where it's like, you're in my office, I'll write you a prescription for an opioid, get out of my office. That's pain management. And I think there's probably people watching and listening right now that are like, what the heck? There's other options out there. You can put stuff in my ear. What's going on? So I think just creating that awareness, and it's just a perfect time during September to do so. So I think that's just so awesome that we can spread awareness about what other options there are. Because I mean, for example, like when I was talking with Nicole last episode, I believe, and porphyria hitting me a little bit harder in the back than it did the stomach. And me knowing that, hey, I didn't pull my back. This is porphyria that's making this happen. And I was playing college hockey at the time. And I was like, I'm just going to play hockey still because I know that this pain is not something that's going to hurt worse. It's just, it's almost like an in my head thing in a sense, or it's my body doing it. But I was able to distract myself and it not hurt so bad when I was playing hockey. So that distraction aspect that you brought up is something that I've experienced too. And I just thought I wanted to ask like how important it is to, and I know you talked about a little bit, just the behavioral, the mental aspect of pain too.
Well, it's interesting because when I'm teaching the neuroscience to not just our patients, because I also, part of my programming is educating staff too. So our facility actually strongly recommends that our staff attend my trainings. So they have a better idea of what is going on, because some of the neuroscience, this wasn't around per se or well talked about, previously. I mean, this has come on the scene in just the last few decades, but I mean, previously pain and disease in and of itself was approached through this, biomedical approach, meaning it was just physical, just in your tissues. For the longest time, I felt like we had pain receptors in our body, but we don't. Actually, what happens is you get signals and sensory information that comes into your system, into your nervous system. those signals and that information can come from a multitude of resources, from the environment, from your tissues, from your medications or treatments. It can come through the senses itself, from what you see, what you smell, what you taste, what you touch. Environment, what I mean by that is it can come from what the weather's doing. Believe it or not, research has shown the weather really does impact how a person feels and how they experience their pain when the barometric pressure changes. And so you get all this information coming into your system, signals, and they get into your through the periphery into your central nervous system. Those signals go up your spinal cord, up the kind of the neuropathic highway, so to speak, and it makes it to the brain, if it does make it to the brain. And so when it does get to the brain, your brain makes the decision, is this dangerous enough to need to protect you? And pain is just that, it's a protection. It's what prevents you from putting your hand on a hot stove. So that's the very basic of pain. I often tell people you don't want to kill your pain, because pain really does play a role to protect you at its very simplistic. If you didn't have pain, think about a diabetic. They can't feel, if they have really bad neuropathy and they can't feel their feet all that well, they don't notice if they're having sores. And if those sores on their feet become infected, they don't know. And then the infections can become necrotic, and then they have to get them amputated. And it's because they don't feel it. So that is evidence that you need pain. You just don't need it to the point where it's hypersensitive, to the point where you're experiencing it 24/7 at extreme levels. So your brain absolutely plays a very huge role, but that's not to say that it's all in your head or you're making it up.
Right.
I've had lots of providers tell me that, oh, I don't see there's anything wrong with you. You know, you just have degeneration, or you just have osteoarthritis. And that's just, you know, everybody has that. So just deal with it. But everybody experiences that differently, and it doesn't mean that their pain isn't real. So it's really educating people about what is truly going on in their system and letting them know that they can do something about it. I mean, arthritis, you actually can reduce some of it by doing some activity and just approaching it different. I talk about distraction and people look at me and they're like, really? So you're telling me that if I distract myself, then it's going to cure my pain? And I'm not saying that at all. It's just a tool. But at the end of the day, if distraction helps to lower your pain levels by 1 or 2 points, that could sometimes be the difference of whether you get out of bed or not in the morning. So all of these tools together can make a huge impact on a person's life and on their overall functioning. Because at the end of the day, we're not trying to kill your pain, we're trying to improve your quality of life.
That's amazing. I'm sorry, go ahead.
I was just going to say, your pain is part of your human experience. It's inevitable. We all experience it, but the suffering piece is really where it's at, that you really need to approach. And that's what I tell my patients. The suffering piece, that's optional. And that's absolutely what we can help you with. And it is treatable.
That's amazing. You've said so much. I think we would need another 3 hours to get to it, but a couple things that I wanted to kind of just go over that you said. I think I've noticed this a lot. You know, you do suffer from chronic pain. You know, we have porphyria. We're doing this. I think it's great. You know, that's not great, because I wish all of us were perfectly healthy. Yeah. But what's great is, you know, knowing what it feels like, knowing what it is, sounds like it has just really informed you and inspired you and motivated you to find another way. And I think it's really great. And everything that you were talking about, you could be I'm sure when people are listening, they were going, yep. Cause I was like, everything you said just about your personal pain, I was in the things that it made you feel, and not being able to do things, and not the difference of getting out of bed or not going to work or whatever. And, when you were talking about the cognitive, part of it, this is all great. And this is something that I really believe that, if patients had access to this more, that they would be able to just have such a better life, exactly as you're explaining. Reality is, for a lot of patients, is that I've looked into going to a functional medicine doctor, acupuncture, doing massages. It helps me. It's very expensive.
Yeah.
Insurance doesn't cover it. And,
Yeah.
what are some ways, and hopefully we'll talk about this more in the future for, the APF and its members, but what are some ways that patients can get the benefit of those other modalities, the training, like a coach to go through and say, just even if it's not quite as intensive and well-rounded as what you're offering, what are there any ways that patients can try to get access to that? Because a lot of people they are on disability or they can't, they're dealing with all this. It's very expensive and it's hard to do. So do you have any advice for them?
I mean, there are some, as I said, I think VA is really leading the charge with regards to this transformational healthcare, with regards to rolling out the approach through whole health. But I also do see that the private sector, the community, is trying to catch up with that. And I do know that there are clinics and practices that are starting to come around and have more of that interdisciplinary team. Part of it is finding it. Another thing would be there's coaching is taking off across the nation. It's a national board certification where there are coaches out there that are legitimate clinical people. They're not therapists. I should also say a coach is not a therapist. They're not going to just address your mental health. They're going to work with you where you're at, because one of the benefits of coaching, and you can find it in the community, you could Google it or what have you. It is out there, but I think one of the biggest benefits, and I hear this from a lot of my patients, is just finding someone, whether that be a coach or even a therapist, to sit down and talk with, because I know what's helped me is having that avenue to have someone listen to me. I hear that time and time again from my pain patients. It's like, when I go in to see my provider, they give me about 10-15 minutes and that's it. And part of that time is, fighting with them about whether I'm going to get an opioid or not, or whether they believe me that my pain is legitimate or real. And oftentimes just finding, it can start with one provider. It could be a coach, it could be a therapist, to really kind of start where you can sit down and share your story and someone's actually listening to you and giving you the time to, tell you what's going on and is wanting to hear it and is wanting to work with you where you're at. So that would be a place to start. I don't know how open people are. I mean, I think mental health has come a long way, but that can be a piece of the puzzle. I think more so than not for people. But yes, I hear what you're saying, Nicole. A lot of these alternative services, 10-20 years ago, they weren't even being covered by Medicare. And right. I know some of them now are, such as acupuncture, chiropractic, but I don't have a solution for the community. I do know that I would challenge people to look for more of I've heard about one-stop shops at chiropractic clinics. They offer a lot of all these services and resources in one place, where they have a massage therapist or an acupuncturist or a pharmacist in-house. So that might be a place for people to look.
Yeah, you just said something too about feeling listened to, and my next question one of my questions was going to say, because Dr. Smith was just on a couple episodes, or I think it was the last one, and he said that he does take the time to listen, and I think that's why he's such a good doctor. He takes the time to figure it out, go take the next steps, go above and beyond. But also he said there's his colleagues applaud him, but the institution is like, hey, there's a lot of pressure on healthcare providers to see a quota of, I don't know if it's called that, but it's you could say that a quota of patients, only spend these 10 minutes. What steps would you say for healthcare providers to be able to listen and address these unique pain experience of rare disease patients or chronic pain patients, even if they don't fully understand the disease, or to make that person feel listened to, even in a short amount of time? Is there anything that you could give, advice on that?
Oh my goodness.
I know I'm sorry.
But no, I mean, part of it is as I mentioned, I work with providers and I try to educate them even on how to talk to patients better and teaching them, more motivational kind of soft skills. I know that's not going to help your patients with respect, but there are some providers that are really good at it and some that are not. I mean, it's always, and I've exercised this, right? It's always the patient's right to get a second opinion or a third opinion. But one thing that has helped me personally is being my own best advocate
Right.
and doing research. I mean, if I can't offer anything beyond that, is know yourself, but also know what you have access to. It may not be all of the things that I've mentioned, but knowing what your health insurance will allow you to cover or what your disability benefits allow you to get. And then creating a team for yourself. I mean, I cannot stress enough how important it is to have a team, not just a provider, but literally either if you don't want to get a psychologist or a therapist, get a coach if you can find. I mean, they're more mainstream than you would think. A life coach or a health coach, they're out there. There are practices. You can reach out. Usually hospitals now are coming up to speed with regards to having more holistic options. I know some of the hospitals in my area, they have support groups and they will also offer like educational topics. I will often go, not just for providers, but for patients to come in and, learning about, say, the anti-inflammatory diet. It is a thing. What we eat really does impact our overall health and our chronic pain. And so checking out where your local hospitals are and what kind of resources they have, because they can have really good resources, whether it's those educational topics or groups, or they offer some hospitals through their physical therapy, they may be able to offer a massage. But doing your research and really being more active in your healthcare, as opposed to being dependent upon your provider to tell you what to do. That's also one of the shifts and pivoting is patients can no longer be just dependent upon their providers to tell them what to do or to, give them their treatment plan. Patient needs to be very educated and involved in their healthcare.
Yeah, well, I also think too, because this is newer, obviously it's, like you said, in the last couple of decades, but I mean, I notice as well that, there is more access, but what I love is that, I think a lot of patients don't even know what to look up. I mean, now that you've brought all these, the cognitive behavioral, the social, all these things, and I think that that they're going to get a lot out of this, out of what you're saying, because now you can identify. That's got to be the start. You have to know where to start, right? And then be able to know what to look for, and then find something that you can have access to. And as I'm a hound, my mom is a hound. We just research until you know what I mean. And if you do that, and like you said, being your best advocate, because nobody's gonna care about you more than you, and getting you healthy. So I'm so grateful that you brought all these things up, because I think if there are a lot of patients, especially when you're not feeling good, especially with porphyria, you're not necessarily thinking straight. So, right. It's hard if you can at least write it down. And then when you're feeling better, take that time to look it up and see what may work for you. It's awesome. Thank you for bringing all that up.
Well, and one thing I think you and I had talked about when we had dinner the other time, a month or so ago, was it would probably be beneficial, and I would put this out, and I would certainly be willing to help, but working with the American Porphyria Foundation to kind of do like an external scan or an audit, so to speak, of what kind of resources are available to porphyria patients, right. In and around, and, what kind of things do help, coming up with at least like that checklist of, these are modalities that have been shown to be beneficial. And these are some of the questions you should ask your provider for this and this and that. I mean, I would love to partner with you to explore that option as well, because you're right. When you're in the mindset or when you're in kind of that suffering mode, you don't have the mental capacity to even think about half of what I just rattled off. I totally get that. And so maybe that's something that the APF might want to explore or take on. I'm certainly happy to partner with you.
Thank you, because like as we were talking, I have this idea too, and I was kind of saying before we even spoke, I was saying, and I'm not, you know, this was just lucky. I was thinking, I was saying it, but you know, basically to treat the whole patient. And I really think that there are, like we were talking about, if we can get something where there are, you know, a survey or questions where we can, you know, I don't know who makes those questions, but you know, find out where maybe have a health score as opposed to like, where am I, like you said, where am I at where I need some help? And if you're not sure, you could, you know, find out and then kind of look at, okay, if you're in between here and here, you know, if this is your thing that you need to work on or that you want to work on because that's your goal, here are some resources to get started. And I think, like you said, just laying that groundwork. I mean, yes, we would love to do that because I think this is so, besides diagnosing and treating, which obviously is, you got to find out what you have, and you have to be able to have treatment, especially with porphyria. If you're not treated, it can cause chronic pain and everything. But
Absolutely.
But so many people, because especially acute hepatic porphyria patients, where the delayed diagnosis is an average of 15 years, they are going to have all these chronic symptoms. So probably, most likely, not everybody maybe, but that's what happens. And so to me, addressing that to have a better life, and you decide what you want that to look like and get the resources to help you. So, I mean, I couldn't be more excited about that.
Yeah, no, I think that is a much needed project because you do bring up a good point. I mean, I'm coming from just this little microcosm of the VA, which is amazing in what they're doing. And I've been truly blessed and honored to be able to create the program that I did. But I know that it's not out there mainstream full force. But I think as a foundation, you guys could really lead the charge in, you know, this is what is available. These are some of the questions that you need to be asking, and let us help you on that journey.
Yeah, no, I think that's awesome. And Andrew, I think you were just going to say something.
I was just going to throw a scenario at you. I was curious, just in a sense of you have people watching, they heard everything that you're saying, they're like, well, I got options. The best thing to do, of course, would be to get a coach and to see what their options are. But for people who are just in chronic pain, sitting at home right now, have gathered up all this information, what could they do right now to just try to manage their pain themselves, would you say to them?
Well, I mean,
a good question.
I also know with some of the options that people can't leave their house and they can't make it out to go to providers. You know, that's where you could also research to do some virtual options. I know that there's a whole wave towards doing like virtual mental health care and offering video options for people where you could connect with a provider just as we're connecting right now through video. So that's an option. But another thing would be I mean, social media, it's a double-edged sword. On one hand, you know, it can be our friend and it can educate us about a lot of things, but on the other hand, we can go down a really dark, deep rabbit hole and we can become Dr. Google and start diagnosing ourselves with like 50 other issues along the way. But part of it, I think, is also looking at how what your perceptions and how you're experiencing your current state. You know, what do you feel about your overall health? I would ask what matters to every single person that is watching this. So ask yourself, what matters to you most about your current life, your daily functioning, and what would you like to see improved? And, you know, for some people, you could start journaling about some of that. And I know people are going to be like, journaling isn't going to help me, but it's a tool. It can start to where you start having that conversation with yourself, where it's like, okay, this is what I've got going on. And, you know, where do I go from here? What are some options? What would I like to see improved? That's something I can't answer for people. That's something that partnering with someone, you can together to answer. But you as a patient, me as a patient, I would definitely recommend start asking yourself some of those questions and then look at, what strengths do you have? Because regardless of how shitty we feel, we all have strengths that we can pull upon. What works for us and what works against us, and what are things that are good about our life and our functioning. And then if there are some of those weaknesses or some things that work against us, identifying those and then starting to have conversations, whether it's with loved ones or with friends or what have you, about how can I find a workaround. I mean, those are some things that people can start working on. I know that's not like the end all be all quick fix, but I will tell you this, there is no quick fix. I wish, and I tell this to my patients, and I have a magical wand in my office that really isn't magic. There is no magical wand for this. As mentioned, I've been struggling with chronic pain my whole life, and I haven't found a fix. And I think that's the flip that has to happen. And the whole transformation piece of this is realizing that the focus shouldn't be on trying to fix all of this and get rid of it. It's how do I live my life to the best it can be? How is
Because
my
that's
function
possible. The other may not be
Yeah.
possible, right? And we can only control the controllables,
Exactly.
And
Exactly.
I wanted to say too, a shortcut way to journal sometimes is, and it actually helps me, is a gratitude journal.
Yes.
Because you can make a list. You don't have to write pages in a notebook. You can just, buy a notebook or whatever. You can write on anything and just say, I'm going to 10 things that I'm grateful for. It can be that I'm breathing right now. It doesn't have to be, and sometimes that was on my list, because I didn't have a lot going on, that was looking good, so, but if you do that, it also reminds you of something, Warren, we didn't mention that Warren, Warren Hudson is your husband. He was on as the caregiver before, but he was saying, reminding that there is something to look forward to. And you can look right now, as bad as you feel, like my dogs, they're always there. If I could be dying, like the love, it's healing. I mean, they're just amazing, so and because journaling, when I hear journaling, if I decide to do it, it's all great. But if I'm like told that I have to do it, I'm just like, oh, you know what I mean? And doing it consistently. So I found the gratitude journal was really easier because it's short. You're just making a list. You don't have to write a novel. You know what I mean? So I just want to put that out there too. It's a little bit of a, hack.
I found that on the reverse side too, because that when I would journal and write stuff down, it was more so I would just have these thoughts that keep me up at night and just constantly were draining. And then you kind of just put it on paper, and then it's like the thought's there now. Like it doesn't have to be in my head. I can go to bed now. So that's really been like the main thing.
Exactly. Yes. And back to what Nicole was saying about the gratitude journal, that is one of the homework assignments that I give to my patients. I'll always recommend to every patient I see, and even my staff. Look for and identify 2 to 3 things that you are grateful for every day. No if, buts, or whatever about it. And they all have to be different. No repeats. So
that was my question.
no repeats. I mean, I hear what you're saying. And there are some times that, I'm grateful for moving. I'm grateful that I took a shower today.
Yeah.
So, and those are, believe it or not, those are things to be grateful for, because we often lose sight when we're feeling so helpless, hopeless, depressed, angry, upset. It's hard for us to get back to appreciating any kind of positive. So doing that gratitude every day, and just have a notebook and literally 2 or 3 things per day. That's all you got to do. And that can sometimes be life altering for some, because they can go back and look and they can be like, wow, yeah, that does make sense. Because as we said, we lose focus of that.
Sure. I know we're not going to keep you much longer, but I had a couple patients.
Sure.
Well, I should say a lot of patients, but just recently, someone brought up that with the DEA, with regulatory changes, with the opioid epidemic, with all these things where patients are either getting their doses cut or they're being restricted where they can only get, a week at a time. And for someone that can't get out, it's hard to go to the drugstore every week, and or have someone else do it. Some of them are controlled, whatever. So I just want to I promised I would ask you this. So I just want to ask, like, what can you say about that? What can patients do? What is there a workaround? I know for me, living in Florida, I had to go to a pain clinic. The doctors here are not, in Chicago at Rush, my doctor was able to prescribe, my hematologist was able to, prescribe for me. And down here, it's just not allowed, which is fine. So I go to this pain specialist, and I'm just going to go through this, not about it's about me, but just to share my experience.
Sure.
You go in and you have to take a urine test, and that's fine because you understand that some people aren't responsible. Maybe they're addicted, and sometimes not even on purpose. But you're treated. I consider myself to be a strong person, but every time I went in there, they treated me like a drug addict. I felt so almost ashamed for nothing, it's like if you tell your dog, like, right now, what did you do? And they didn't do anything, it's kind of like that. You just feel like you feel horrible. And every time I go there, I would end up crying. And then I would and then on the other side, I would go in and they would say, you don't take enough pain medication, so you don't have chronic pain. So, I don't know if I can really give this to you. Your insurance isn't going to cover it because you don't take enough. And I was just like, my goodness, what I said was, so you're telling me I'm being punished for being responsible? Because I actually should take it more often than I do, but I don't, what I mean? So because of that, I've just always been that way, So, I felt kind of like talking to other patients sometimes, and I hate having this attitude in general, but sometimes it feels like that when you're in that situation, is that you can't win, and are there any changes coming that are going to help patients? What can they do? I remember once I was in the hospital in an acute attack, and the doctor came in and said, and brought in, and it was, the medication was in half. And I just asked why, because it wasn't a high dose in the first place. And it just, there was no reason, and they fixed it. But, I have a big mouth, and I just kept asking about it. And, sometimes it's hard to do that. So, I guess in general, for just addressing that, because what we're talking about, which I love everything we've talked about, is those are other things that we can do if we can't deal with this problem. But this problem is rampant right now, and patients are desperate. Like, what can we tell them to help them right now?
Nicole, I wish I had an answer for that. And you know what?
I know there isn't.
I do and I don't. I mean, I can honestly say I've been in those same shoes. I mean, recently, because I'm on pain medications, and I've had it where insurance company won't cover it. And what used to cost me $15 now can cost me $800. Or, I'm sorry, we don't have any in stock, when I know they do. And part of that is being an advocate for yourself. That's one thing. Another thing, I couldn't do this by myself. So I'm speaking as a patient right now. I couldn't do all of this and function like I do without Warren, who is an amazing, amazing person, but he knows about me. He knows about my pain. He knows about what medications I'm on. He knows my symptoms, and he can tell. So that's the other piece of this. Talk to your loved ones and get them up to speed. So if you can't advocate for yourself, find someone that can, because I do know what it's like when you are in such a horrible state, as I know some porphyria patients get into when they're having an acute attack. They can't speak up for themselves. And so that's when a caregiver can be so incredibly helpful. But yes, with regards to insurance and providers, I mean, it's run the gamut. I even work with providers now who just absolutely refuse. And they're like, your clinic can prescribe opioids and pain meds, but we're not going to. So you can just keep the patient. And part of that, I mean, some of this is systemic. So it's changing the system. Unfortunately, I can only do so much, but I'm fighting on all different levels, regionally, locally, also nationally. And I know back in 2016, when the CDC came out with pain guidelines, it's like the pendulum swung one way completely. And it's just like, take everybody off opioids, get rid of them. And providers then got all skittish and they're like, nope, not prescribing anymore. And they would approach you. I mean, when that happened to me, I was no longer able to get any pain meds or any pain treatments from a primary care provider. And so they're like, go see a neurologist. That neurologist accused me of being an addict. And then I was switched to a neurosurgeon. Well, on your MRI, it doesn't show anything that's warranting surgery this time around. So sorry. So then I had to go from doctor to doctor to doctor. And then it looks like you're doctor shopping. But I finally found a pain clinic and an amazing empathetic provider that works with me, and he listens to me. And I would recommend advocate for yourself, but don't give up. There are providers out there. Since 2016, nationally, they have started to come down on providers that are abandoning patients, particularly because there's been a huge increase in overdose. Because patients are getting it on the street, they're taking things that are laced, that are not safe. And so that's another issue. I literally just did an outreach event on International Overdose Day, which was August 31st. Another thing to protect yourself is to get a Narcan kit just in case. But with regards to how to deal with this, I know that nationally legislation is trying to bring the pendulum back. They do state that opioids are not the first line of defense, but they also say in the next breath, you can't abandon your patients either. And so part of it is educating providers about all of this. There are going to be some providers that they're more about protecting their license or what have you. And so with that, I would recommend find a new provider. I don't know if that's always possible, but again, it's being your best advocate for yourself. I wish I could fix all of that. I really do.
Well, you've done as much as you can to fix it. You've done, this is just incredible what you've created with the VA. I mean, when you were telling me about it, you're talking about it today. I mean, it's just exactly it's so needed. And I can't wait till that kind of trickles down into the private, sector, and just be able to have more access to that. And, the other,
I guess what I would say is don't ever stop advocating for yourself. And just because a provider says, or treats you wrong, you don't have the right to be treated that way. You don't have the right for a provider to abandon you. That is not okay. Speak up, because you do have a voice with regards to who you are and what you're struggling with, and let them know, and keep speaking up until you can find someone that will listen to you. I know that's not always easy, but that's exactly what personally I do and what professionally I tell my patients to do.
I mean, it's a short-term thing to battle your way to get the answers you need. Because I know there's a lot of people out there that are just saying, you know what, it was too much work to build this team that I spent years doing. I'm not going to do it. But I mean, you look at both sides of it, and you spend time digging for more answers and for someone who will actually listen, and it really just offsets the rest of it. So
it does. And I mean, it's, again, going back to what I was saying with regards to the cognitive behavioral stuff, is where do you want to put your energy? Do you want to put your energy continually in the negative about I'm helpless, there's nothing I can do, and the situation is hopeless? Or can you look for and use your voice to find things that you can control? So it's literally flipping the script. And I know it's a transformation systemically, but it's also a different way for patients to look at it. Patients don't have to be helpless, and they don't have to suffer. As I mentioned, there are a lot of tools out there. They may not be available for everyone, but they need to look inward and look at their strengths and know that they have the right to advocate for themselves. The stuff with like urine drug screening and, pain contracts or informed consents or what have you. Those are risk mitigation metrics that providers have to use in order to help with regulation, but that's why they're there, is so they can continue offering treatments that patients need. So they have those risk mitigation metrics so they can prescribe or approach care in the best evidence-based way possible. So I don't know if that helps.
It does. And I'd like to add one thing. If staff at these pain clinics or, that are educated the way you educate your staff, it's I don't mind having to do the urine test. It's the attitude,
I know.
so teaching that emotional intelligence, is I think really important. And that's something I think it's definitely the tide's changing, and especially with people like you. I mean, you're just at the cutting edge of changing this, and I'm so excited. Thank you so much for sharing everything. This has been absolutely incredible. And like I said, I want to keep going for hours. I could pick your brain, but
no, Nicole,
really
I'm happy to come back.
Well, great. Well, now we have it, and it's no, I'm just kidding.
Yeah, it's on paper now.
Sure.
Well, I mean, I thought, yeah, that's a good place to wrap up. Unless you have another question, Nicole, or unless Judith, you had something else that you wanted to mention to everybody listening or watching.
No, I think I said a lot.
You did. Judith, that was amazing. Thank you so much.
Thank you. Thank you for taking the time out of your day to listen to our podcast. If you enjoyed this episode, please share it with friends, family, or anyone who could benefit. And please don't forget to subscribe and leave a review on your preferred platform. It helps us spread awareness, and we would be extremely grateful. You can also follow Rarely Discussed on Instagram, YouTube, as well as TikTok. If you're someone seeking diagnosis for porphyria, visit porphyriafoundation.org to receive a free doctor packet, forms for free DNA testing, and a list of doctors in your area. Stay tuned for more episodes of Rarely Discussed.